Talus fractures. Epidemiology. Second most commonly fractured tarsal bone. Talar neck fractures account for 50% of all injuries to the talus. Anatomy. 1. Head. Directed forward, slightly downward, and medially. Articulates with the navicular bone. 2. Neck. 15 to 25 degrees medial deviation from the long axis of the body. Deep groove on the plantar surface, talar sulcus. Talar sulcus plus calcaneal groove tarsal canal, contains interosseous talocalcaneal and cervical ligaments. And 3. Body. Upper surface, trochlear articular surface. Medial and lateral surfaces, articulate with malleoli. Lateral process, wedge-shaped. Posterior process, contains medial and lateral tubercles separated by a groove for the flexor hallucis longus, FHL, tendon. Accessory ossicle, os trigonum, posterior to the lateral tubercle. If fused, staidas os or trigonal process. Blood supply. Posterior tibial artery. Dominant supply via the artery of the tarsal canal. Deltoid branch of posterior tibial artery. Supplies the medial portion of the talar body. Anterior tibial artery. Supplies the head and neck. Perforating perineal artery. Supplies the head and neck via the artery of the tarsal sinus. Clinical relevance. Limited vascular supply due to a. Large articular surface, 60% of external surface. b. Lack of muscle attachments. Talar neck fractures, especially displaced, can lead to avascular necrosis, AVN. Mechanism of injury. 1. Axial loading or falls from height, e.g., FFH. 2. Forced dorsiflexion or plantar flexion. And 3. Twisting forces, often associated with subtalar or ankle dislocations. Imaging. 1. X-ray. Connolly view, optimal for neck visualization. 2. CT, detailed fracture assessment. 3. MRI, detects occult fractures. And 4. Bone scan, useful for occult or stress fractures. Classification. 1. Anatomical classification. Lateral process fractures, posterior process fractures, talar body fractures, talar neck fractures, talar head fractures. 2. Hawkins classification, specific to talar neck fractures, Nile SAT. Group 1, non-displaced. Group 2, subtalar subluxation or dislocation. Group 3, subtalar and ankle dislocation. Group 4, Connolly and Kelly, associated talonavicular subluxation or dislocation. Management. 1. Conservative. Indications. Non-displaced fractures, less than 2 e.g., Hawkins type 1. Methods. Leg cast for 6 to 8 weeks. 2. Operative. Indications. Displaced fractures, greater than 2 Hawkins type 2, 3, IV fractures. Comminuted fractures or non-unions. Methods. CRPP or ORIF. Fixation. K-wires, mini-plates, for significant comminution, interfragmentary screws. Titanium screws for MRI compatibility. Medial malleolar osteotomy, may facilitate reduction. Approaches. Anteromedial, anterolateral, posterolateral, for talar body visualization. Complications. 1. Avascular necrosis, AVN. Related to initial fracture displacement. Hawkins I, 15%. Hawkins II, 20 to 50%. Hawkins III, 50 to 100%. Hawkins IV, up to 100%. Hawkins sign. Subchondral osteopenia on mortise view at 6 to 8 weeks, indicating talar viability. Presence excludes AVN, but absence is not diagnostic. 2. Post-traumatic arthritis. Common due to articular surface damage. 3. Malunion. Typically varus malalignment. And 4. Non-union. May require further surgical intervention.